You see here, whenever a question of arrhythmia is coming, the first thing you will see is QRS complex. So if you see the QRS, this is a narrow QRS. So just I'm giving you a trick to answer this. When you see narrow QRS, it will be an atrial pathology. It will be an atrial arrhythmia. So these two options are ruled out. These two options are ruled out. So remember, ventricular arrhythmias, which means a ventricular tachycardia, ventricular fibrillation, they will have a broad QRS. Now, if you see, like all of you are knowing, I think, like atrial fibrillation is characterized by absent P wave. Here you can see P wave is present, so that is again ruled out. So answer for this question will become PSVT, paroxysmal supraventricular tachycardia. So let me teach you something with ma'am about physiology and pathology in medicine of about all the different type of arrhythmias. What are the conduction pathways? So starting with the ma'am.
Yes. So let's look at. We know that heart has the property of automaticity. Any part of the heart can become the pacemaker, but the normal pacemaker of the heart is the SA node. So the impulse will originate from the SA node. It travels to the AV node via 3 internodal tracts, the anterior, middle and posterior. And the time taken to reach the AV node is just 0.03 seconds. Now there is a nodal delay. The nodal delay is 0.09 seconds or 92 milliseconds. Now what is the reason for this nodal delay is? This is because the AV node fibers are small diameter fibers. This was asked as an INI-CET question as well. What is the reason for nodal delay? Small diameter fibers. Smaller the diameter, lower is the velocity of conduction. The second important reason why there is a nodal delay is because there are very few gap junctions between the AV nodal fibers. So because of this, the impulse slows down as it passes through the AV node. Now, what is the advantage of the nodal delay? The advantage is that all 4 chambers of the heart do not contract at the same time. The atria will contract ahead of the ventricles, which is very important because you know that the last part of the ventricular filling is because of atrial contraction. So this nodal delay helps the atria contract ahead of the ventricles. Now, so if you look at the timeline here, it takes 0.03 seconds to reach the AV node, nodal delay of 0.09 seconds. Plus the time taken to cross the bundle of his, another 0.03 seconds. So 0.03 seconds to reach AV node, 0.09 to cross the AV node, 0.03 to cross the bundle of his, a total of 0.15 to 0.16 seconds from start. So the time taken to reach the 2 bundle branches is 0.15 to 0.16 seconds from start. Then the impulse spreads to the 2 ventricles. The endocardial surfaces will depolarize first, followed by the epicardial surface. So as you can see over here, in about 0.19 seconds, the endocardial surfaces of the 2 ventricles are depolarized, and about 0.21 to 0.22 seconds, the epicardium is also depolarized. So by the end of 0.22 seconds, the entire heart is depolarized. A little bit about the different waves in the ECG, genesis of the ECG. Now this is a very interesting diagram. We know about the P wave. P wave is atrial depolarization. QRS complex, ventricular depolarization. But there is a particular pattern in which the ventricles depolarize. The first part of the ventricle to depolarize is the left upper part of the interventricular septum. And then the septal depolarization is from left to right. And because of that, you can see over here is the Q wave from left to right. Then the direction of spread is towards the apex, first the endocardial surfaces and then the epicardium. The last part of the ventricle to depolarize is the base of heart. Base of heart is located posteriorly. It is also called the posterobasal part of heart. So this is how the depolarization spreads, and that is what is responsible for the QRS complex. This is due to a changing direction of wave of depolarization in sequence. Now when I look at the repolarization, now repolarization is responsible for the T wave. Now what happens in the repolarization is, depolarization is endo to epi, repolarization is epi to endo. So this is one thing that you have to understand. The ventricular depolarization was endo to epi, but the repolarization, the direction reverses. It becomes epi to endo. That is why we get a positive T wave. T wave is ventricular repolarization. Now, why is it a positive T wave? So many times, depolarization is due to influx of positive charge. Repolarization is due to efflux of positive charge. So, if it was only due to a movement of charges, the repolarization wave should have been a mirror image of the depolarization wave. It should have been a mirror image of QRS complex. But that's not what has happened. Because along with reversal of charges, there is a reversal of direction. Instead of being endo to epi, it is now epi to endo. So two changes have happened. There is a reversal of charge and there is a reversal of direction, which gives rise to a positive T wave. So these are the basics of the P, QRS and T waves.
So now let us discuss something about arrhythmias. So how to approach a question in INI-CET paper. So whenever you see a question on arrhythmia, so first thing you want to focus, understand this, you have to see something called QRS. So whenever we see QRS, so there are two possibilities. Either we get a normal QRS, normal, or we can sometimes call this as narrow. Or what we can get a broad QRS. This broad QRS is also called as wide QRS. So this should be your approach, understand this. So normal QRS means this is a problem above the ventricle. Above the ventricle means we call this supraventricular, or we can call this atrial. And if I say broad QRS means this is a problem where in the ventricles. This is something that you should remember. Now just try to understand this. After looking QRS, what is our next job? We have to see the RR interval. So next thing what I am looking on, RR interval. Now this RR interval can be regular or it can be irregular. If it is regular RR interval means you can see the distance between each R, it is fixed. Or approximately I can suppose it is like 5 small box or 3 small box. So if it is regular, then this is called your PSVT. And if you see like RR interval is irregular, in that case you have to see P wave morphology. In that case, what I am looking on P wave morphology. So possibilities, you can get 3 different type of P. So when you get more than 3 types of P, so there can be like just I can say P can be like a normal P, it could be an inverted P, or it could be a P mitral, or it could be like a P pulmonale. So when you see 3 different type of P, that is something what we call this MAT. MAT means multifocal atrial tachycardia. And sometime when you don't see P, there is no P, then that is what we call atrial fibrillation. So these are 3 arrhythmias which they frequently test in exam: PSVT, MAT and atrial fibrillation. The same concept, same logic you have to use when you see wide QRS. So again in wide QRS also I am looking on the same thing. I will say RR interval. RR interval. If RR interval, this RR interval, if it is regular, so there I have used the term PSVT. So here I will call this as VT. This will be ventricular tachycardia. If it is irregular, in that case, what we are doing, we are checking for, now see here we are checking for P wave because it's about atria. Now here what we are checking about QRS. If you see the QRS, when you see the QRS, there is a possibility you will get 3 different type of QRS. So it could be like smaller, bigger, or it will be normal size. So you can see 3 or more type of QRS. Or sometime like we cannot see QRS. We call this unidentifiable QRS. Unidentifiable QRS. To understand this, when you see more than 3 type of QRS, this is called torsades. Torsades de Pontis. So we also call this a ribbon pattern in ECG. And if it is unidentifiable, then what we call, it means it is merged with P wave. We call this ventricular fibrillation. So again, here also you have to remember 3 important arrhythmia. First is VT, second is torsades, and third will be ventricular fibrillation. So this is like based on QRS, we can classify different types of arrhythmias. And remember, in AIMS exam, they are testing your knowledge on these 6 different types of arrhythmias. Now, out of this, what I want to tell you here is,
Just one second, Dr. Aman. I think this part is hidden. If that's behind us, if we can just highlight, because it's a fantastic algorithm which sir has given, and I don't want students to miss out. Is there some way that
okay, can you see it now?
I can move out of the screen if that helps?
We will be sharing the PDF in that.
But excellent algorithm, sir.
So this is like a flow chart or an algorithm that you have to remember to understand different types of arrhythmias. Now they can ask you a little information about each of this. So starting with the first one, that is PSVT. Starting with the first one, this is your PSVT. So remember, most of the arrhythmias, they are more common in males. In fact, I can say most of the heart disease are more in males. Why? The reason is, you know already the reason, there is estrogen. So estrogen is protective. This is only arrhythmia is common in females. PSVT is something that is common in females. If you ask me what are few things in cardiology which are more in females, one is in front of you, that is PSVT. If you ask me the next thing which is more common, can any of you can comment on this, which is more common in females, which cardiac disease? This is transmental angina. Transmental angina is something that is more common in female. And the third is, anyone? Trending topic, trending type of cardiomyopathy, I can give you a hint, that is called Takotsubo cardiomyopathy. So these are 3 cardiac disease, and remember, most others are more in males. So these are the conditions which are more in females. So PSVT, what type of question they ask you in exam is like, this is a type of arrhythmia which can be triggered because of stress, because of emotions, or sometimes it can be due to some drug abuse, like especially some drugs like of abuse, like I can say amphetamine. So amphetamines, cocaine, tobacco, these are the drugs which can precipitate the attack of PSVTs. So the specialty about this arrhythmia is, for all arrhythmias, the gold standard and the best test is ECG. So when you do the ECG, suppose today the patient is coming to you and he is having palpitation. So you suspect some arrhythmia, you are doing ECG. So during attack, ECG during attack, this will be abnormal. In the same patient, if you do the ECG next day, the next day means after attack, maybe the same patient which is having PSVT, next morning or after a few days, ECG will come normal. Another MCQ that they ask in exam is, in which arrhythmia you can see a normal ECG later on, that is PSVT. Now understand this, the symptoms, it will have similar symptoms like any arrhythmia. There will be palpitation. Palpitation is feeling of one's heartbeat. But here you will see this palpitation is sometimes followed by release of ANF. So there is diuresis. The patient will have palpitation followed by diuresis. Sometime there will be some other complaint, like patient can also have shortness of breath, right? The patient can have hypotension. But remember, these are not necessarily to be present, but most patient they'll come to you with palpitation. So now you are performing ECG. In ECG you are seeing this. So what you should do to manage this PSVT? So diagnosis I already told you, that is ECG. So now treatment will depend whether it's a stable patient or it is an unstable patient. So the question which I showed you, that is the patient BP was normal. So it was a stable patient. In stable patient, what is the first thing that we do? We do vagal maneuvers. So vagal maneuvers means it could be a carotid massage, or we can also perform Valsalva. 85% to 90% PSVT, if it's a stable patient, they terminate with this thing. So understand this, I am writing here 85 to 90% chance of termination. So first thing, the question they ask in exam is, first thing you will try in a person with PSVT who is stable, that is vagal maneuvers. If it is not terminated, then you'll go to the next thing, that is we will give IV adenosine. IV adenosine. So adenosine is available in 6 mg, 12 mg, 18 mg. So 6 to 18 mg. The question is like this is having a very short T half. So whenever we give adenosine, so remember we give adenosine 6 mg, and straight away we will give 5 to 10 ml or sometimes 20 ml of normal saline. This is followed by a rapid saline push. Rapid saline push. Understand? You can give one dose 6 mg, wait for 5 to 10 minutes, then you can give 12 mg. If it is not terminated, then you can give one more time 12 mg. So up to 3 times we can repeat. So 6 mg, 12 mg, 12 mg. If it still failed, then what we have option, that is cardioversion. Then what we can do cardioversion. This is the algorithm for stable patient. If patient is unstable, don't do anything, straight away the treatment will be cardioversion. So that is something you should know. Like PSVT, they will ask you multiple questions from this. First will be, what is the initial treatment of choice in a stable patient? The answer will be carotid massage. Second MCQ is, what is the drug of choice? Drug of choice will be adenosine. Or they can sometimes give you a question, they will give you PSVT, they will mention PSVT, and they will ask you like patient BP is 60-40, or that's an unstable patient. In that case, the treatment of choice will become cardioversion. So now, as you know, for any arrhythmias, there are two possibilities, two reasons. First is there will be a defect in automaticity. So that I can say there is a defect in impulse generation. Or the second problem is, means your SA node is having more pressure. Or second possibility is there will be defect in impulse propagation. Defect in impulse propagation. Understand, defect in impulse propagation means there are two possibilities. First is what we call this, there is some kind of re-entry. We call this re-entry phenomena, and arrhythmias that trigger because of this re-entry phenomena, we use the term AVNRT. AVNRT means AV nodal re-entry tachycardia. Sometimes this impulse is propagated abnormally because of some aberrant pathway. So you know, like a common disease, WPW, Wolff-Parkinson-White syndrome, that is due to aberrant pathway. So if any person is developing arrhythmia due to this aberrant pathway, then final solution is you have to there should be ablation of this aberrant pathway. Is it clear? Most of the PSVT, they will occur because of re-entry, that is nodal re-entry, or what we call this AV nodal re-entrant tachycardia. Okay, in this list, just I want to add some more thing, like how to treat. Sometimes they ask you the treatment part of different arrhythmias. So like we know, we have four classes of anti-arrhythmic drugs. So class 1, class 3, class 2, class 4. So this was in pharmacology textbook, we call it as a Vaughan-Williams classification. But like there is one more class that is called class 5. So this class 5 is also called as miscellaneous class. So these are total 5 classes of anti-arrhythmic drugs. Now you know, like in class 1, what we have 1A, we have 1B, we have 1C. Now understand why I have written this, to make it very simple. Understand this 1 and 3, what type of number these are, even number, odd numbers. So these are the drugs which are used, or which we call them rhythm controlling strategy. Rhythm controlling strategy. So what is the meaning of rhythm control strategy? Means these are the drugs generally we recommend in IPD patient. IPD patient means these drugs are toxic. They themselves can precipitate another type of arrhythmia. So these are the drugs, these are given on IPD basis. Class 2 or class 4, class 2 or class 4, I can say this class of drug, we call them, they are relatively more safe. So these are what we call rate control strategy. Rate control strategy, and these drugs we can give the patient when we are discharging them in OPD basis. And these are relatively more safe. Now understand, class 1 and class 3, rhythm control strategy, IPD basis, class 2 and class 4, rate control strategy, OPD basis. Then what we have class 5, this is a miscellaneous class. So suppose nowadays we don't use class 1. In practice, we don't use them. This is like something which is outdated. So you know, you have studied some drugs mexiletine, flecainide, these are no longer used. So nowadays in IPD basis, what we prefer, yes, your favorite amiodarone, dronedarone, ibutylide, these all are in class 3. To understand this, class 2, you know, class 2 is beta blocker and class 4 will be calcium channel blocker. So suppose in any question you are not knowing anything about the treatment part, and they ask you like it's a patient who is unstable, and patient you are admitting in ICU or an emergency. In that case, we will prefer class 1 and class 3. Simple. So generally in MCQs, the option they give is amiodarone, ibutylide, lidocaine. So lidocaine is in class 1 and amiodarone, dronedarone, ibutylide in class 3. Suppose they will give you like a patient who is having arrhythmia, and you discharge the patient on OPD basis. Which drug you will give? You will give either a beta blocker, or we can give calcium channel blocker, which is non-DHP. Non-DHP means that is verapamil and diltiazem. Now this class 5, this is the class which is having rare drugs, I can say. And all these class 5, remember, these are DOCs, very very important, and they frequently test this class in exam. So in this class 5, the first drug is adenosine, which we have just discussed. So first important thing is all these drugs are DOC. Next important thing is all these drugs are given by IV route. So adenosine, I told you this adenosine is the drug of choice for PSVT. Second class, what we have atropine. Second drug in this class is atropine. Atropine is a drug that is drug of choice. I can say we have this only one option we have for bradyarrhythmias. For bradyarrhythmias, where we have to increase the heart rate, what we are giving? Atropine. Third drug here, what we have MgSO4, magnesium sulfate, MgSO4. This magnesium sulfate, MgSO4, it is drug of choice for Torsades de Pontis. The fourth drug, what we have, this is the drug which is having inotropic action, digoxin. So digoxin again, nowadays we don't use this routinely, but remember it is the drug of choice in a condition whenever a person is having atrial fibrillation with heart failure. In that case, we have to give digoxin. So this is the 5th class and these are all DOCs and all are given by IV route. So this is a simple classification. Suppose they can ask you a new question on arrhythmia. So remember, sick patient 1 and 3, stable patient OPD basis 2 and 4. So this is about the classification of anti-arrhythmic drugs and I'm expecting a question either pharmacology or medicine question in exam from this topic. Over to ma'am.
Fantastic. I think this, you've simplified it so much. And just one little point, a question which has been asked, adenosine acting on which potassium channels? This particularly acts on the KACH channels, and this is in phase 4 of the pacemaker potential. So this question has been asked. Vagus as well will activate these channels in phase 4 and so does adenosine. So this was very, very interesting. And now let's go on to our next question. And this is on hyperkalemia.
Okay, so you can see like in AIIMS exam, there is always a question on ABG analysis and electrolyte imbalance. So this is like a record from past 7 to 8 years I am seeing. In every attempt there is a question. So you can't go into exam hall without seeing this topic. And trust me, ABG and electrolyte, they seems to be difficult topic, but they are very easy. In most of the time from electrolyte imbalance, they'll ask you the treatment of hyper part, because hypo part treatment you already know. Hyponatremia, what you have to give? Sodium. Hypokalemia, what you give? Potassium. Hypocalcemia, calcium. So they will not ask you that thing, they will ask you hyper treatment. So try to answer this. Yes, Shipra, the answer is correct, MgSO4. Answer is MgSO4. So what are the possible options we have for hyperkalemia? How we manage hyperkalemia? Hyperkalemia means when your potassium value is more than 5. From the range of 5 to 5.5, we call this spurious or pseudo hyperkalemia. This can sometimes you can see like because of fist clenching, sometimes we do when we are having a blood test, or sometimes it is because of the artifact. So that is called spurious or pseudo hyperkalemia. Even some drugs like ACE inhibitors, ARBs, beta blockers, they can also cause mild to moderate hyperkalemia. But treatment generally, if you see a person with having potassium of 5.6, 5.7, straight away don't start the treatment. Repeat the test again because we have to check it is pseudo or not. Is it clear? Even artificial cooling of sample can also cause pseudo hyperkalemia. And remember, mark my word, most common cause of hyperkalemia in clinical world is pseudo. Because like in India, we have a huge number of patients, sometimes there's artifacts, and most of us, what we do when we have a blood sample, we clench our fist. So understand hyperkalemia, suppose if you have on the second test, you are having again potassium value like 6.5 or 7, how you will manage this? This is one of the dangerous complication. So you have to manage this. So we have 3 things what we can do is, first is we can give something which will act as an antagonist to potassium. Second thing which I can give is something called the potassium which is coming, which came in the blood, that has to send back into the cell. So that is what we call this redistribution. So you can send them back, redistribution. And suppose sometime what we can give something to remove this. How we can remove this? We can remove this by giving diuretics or binders. So these are 2 options. So now understand this. If you ask me antagonist of potassium, so we have drugs here like calcium gluconate, which is our option number A. We can also use calcium chloride. Okay, do not give calcium carbonate. Calcium carbonate is calcium supplement tablet. So that is used to treat chronic hypocalcemia. And even that is not available in IV form. So what we give calcium gluconate, calcium chloride. In redistribution, what we can use insulin. Insulin and beta agonist drugs like salbutamol or albuterol. In India, we prefer salbutamol. In America, they prefer albuterol. Now, how we can remove this excess potassium? So we can give some diuretics. So other than potassium sparing diuretic, we can use any diuretics, but the diuretics which is having fastest action will be a loop diuretic. So you know your favorite injection, Lasix, furosemide, torsemide, these are loop diuretics. Other than this, we can give binders. These are potassium binders, so they will bind potassium. Can anyone tell me the name of potassium binders? What we have? Potassium binders. In short, we call them K binders. K for potassium. Yes. So these are drugs like patiromer. Patiromer. And we have next drug is SPS. Sodium polystyrene sulfonate. And second is sodium zirconate. Sodium zirconate. So these are the available options. Now see, we can use calcium gluconate, that is antagonist, we can use insulin, we can use salbutamol, MgSO4 we use to treat hypomagnesemia, and in arrhythmia that we have discussed, that is tosadis. So this is the treatment part about hyperkalemia.
Yes, so Shipra wants to know how beta agonists help in redistribution. Excellent. We've got insulin as well as salbutamol or beta agonist, and this physiology will answer this for you. This is because insulin, epinephrine, they have they increase the activity of the sodium potassium ATPase pump. And once you increase the activity of the sodium potassium ATPase pump, it causes the movement of potassium into the cells. So there is an inward movement of potassium, and similarly a beta agonist will also do something like this. Similar thing, causes movement of potassium into the cells, and that is used in the treatment of hyperkalemia. There was a very interesting question on treatment of hyperkalemia: A, insulin or insulin plus dextrose? So obviously the answer will be insulin plus dextrose, because obviously insulin can cause hypoglycemia. Yeah. So this was one of the interesting.
Because you have to give a lot of insulin, it will be not like 1 unit, 2 units. So what we are using like 25 to 50 units of insulin. So that can cause a profound hypoglycemia. So that is why we give insulin plus dextrose.
Just a little bit of physiology as far as potassium is concerned, because potassium is an extremely important ion when it comes to the resting membrane potential, excitability of the cell. We know that the extracellular potassium is in a very, very narrow range of normality, 3.5 to 5 millimoles or milliequivalents per liter. Now, what is the role of potassium? Now, potassium is in a higher concentration inside the cell, and the cell membrane has is highly permeable to potassium at rest. When I say a cell membrane is permeable to potassium at rest, that means at rest the maximum number of leak channels which are open are those for potassium, because of which potassium will move from higher to lower concentration. Where is the higher concentration? Inside the cell. Lower concentration? Outside the cell. So potassium tends to move from inside to out, and because the inside of the cell loses positive charge, so inside of the cell will become negative with respect to outside, which is called the resting membrane potential. Most neurons in our body have a resting membrane potential of minus 70 millivolts. Please understand, this is a potential, negative potential inside with respect to outside. Now, let us discuss what happens when there is a hypokalemia and what does it do to the resting membrane potential. Now, we said that the potassium inside the cell is 140, outside is 3.5 to 5, let's take it as 4. Supposing there is a hypokalemia and this reduces to 2, which is a very severe hypokalemia, but what has happened to the gradient now? There is an increased gradient for potassium. More gradient means more movement of potassium from inside to out, and that means more inside of the cell is losing more positive charge, so inside becomes more negative, resulting in a hyperpolarization. Hyperpolarization, so instead of a minus 70 millivolts, it may be minus 80 or minus 85, minus 90 millivolts. If a cell is hyperpolarized, what happens to the excitability? It reduces. Now, which are the two excitable cells in the body? Neurons and muscles. Neurons and muscles in hypokalemia are hyperpolarized, reduced excitability. What is the patient going to complain of? The patient is going to complain of a muscle weakness. So commonly with loop diuretics, sometimes when you have patient on loop diuretics for a long period of time, of course you give them pot chlor, but sometimes if they've not been taking pot chlor, they go into hypokalemia and he comes back to Aman sir with हाथों पैरों में जान नहीं है. That is the common complaint. There is a muscle weakness. Now let us see what happens when there is a hyperkalemia. Now if there is a hyperkalemia, it has dual effects. A mild to moderate hyperkalemia and a severe hyperkalemia. Now I'm not sure, and correct me if I'm wrong, most books say what is a severe hyperkalemia is a potassium more than 8. I'm not sure about whether you agree.
Even in some books it is written like more than 7 is also considered severe.
So more than, we'll correct this to more than 7 because I will trust medicine more on this.
What we assume is anything more than 6, we consider this as equally life-threatening. So any type of hyperkalemia, if you see like first is, if it is pseudo hyperkalemia or like 5.5 to 6, that is like patient will improve. But anything when you see more than 6, you have to manage with proper efforts.
Absolutely. So let us see why is it so dangerous. Now, when if it is a mild to moderate hyperkalemia, that means potassium up to 7, let's say, if we take it as 6 to 7, we take it as mild to moderate. Now the gradient reduces. If the gradient reduces, there is less potassium efflux, more positive charge inside the cell. So inside of the cell becomes less negative, cell is depolarized. When I say depolarized, that means instead of resting membrane potential of minus 70, this is about minus 60 millivolts, and that means now there is increased excitability. So we see arrhythmias. This is one of the conditions where it could lead to cardiac arrhythmias. But if there is a severe hyperkalemia, yes, there is less gradient. Yes, there is less movement of potassium from inside to outside. Yes, the cell is depolarized, but this has been described as a persistent depolarization. And this persistent depolarization paradoxically reduces the excitability. Why does it reduce the excitability? Because now the sodium channels go into what is known as an inactivated state. When they go into an inactivated state, you cannot open these sodium channels again. So in fact, there is a decreased excitability, and we know that, especially let's say, for example, if you look at the heart, if there is a reduced excitability, there will be reduced contractility. So what happens to the heart? Now the systoles of the heart start becoming weaker and weaker, and the heart tends to become flaccid, heart tends to dilate, and this heart will eventually stop in diastole. That is what makes it so dangerous as far as hyperkalemia is concerned, and that's exactly what sir told you, that the important thing is to treat it early and treat it properly. There is an eventual risk of the heart stopping in diastole. I'm not sure if we still, I remember this from my college time, that on chest x-ray, supposing there is a spotter, there is a dilated heart which was seen in one of the differential diagnoses. Is hyperkalemia?
Yes. Hyperkalemia, like the cause of death is still diastolic cardiac arrest. So patient will die because of cardiac arrest. Now, one more thing, I just got a question that came in my brain. Last year, INI-CET, there was a question like which drug will cause mild to moderate hyperkalemia. So, like options were pretty similar, but remember, I told you like ACE inhibitors and ARBs. So, the answer for this question was lisinopril. Lisinopril is ACE inhibitor. ACE inhibitors, ARBs, they can cause mild to moderate hyperkalemia, and that is like around 5.5 to 6, potassium in the range of 5.5 to 6, which is called asymptomatic. Is it clear? So remember, asymptomatic hyperkalemia can occur because of ACE inhibitor and ARBs. And when you see like patient with hypertension, so most of the patient in India, they are taking ACE inhibitor or ARBs. This is something which is commonly seen in practice.
So we can go on to the next question. Now this is...
Okay, so this is like a question which is frequently repeated question in exam. So frequently repeated means they test you this question again and again. So first see the question carefully. Elderly patient, known case of diabetes, right? So okay, there is a doubt here. FMG वालों के लिए भी integrated low. Okay, we'll do that too. Don't worry. Next month we will plan on that also. So you can see like patient is having a case of diabetes. So this is the first hint. And remember, any question they'll start with the age. So elderly is mentioned, means that's also a hint in MCQ. Now focus on the BP. BP systolic BP is 80, diastolic is 50. So BP is very low. So might be this patient is in shock. Serum sodium value is 145. So for this question, you have to remember the normal sodium values. There is a dry tongue, means patient is dehydrated. Urine ketones are negative. Now first you have to tell me the diagnosis. What could be the diagnosis in this case? Johnny Wick, can you tell me the diagnosis first? What do you think? You can see the question: elderly patient, diabetes, urine ketones are negative, BP is 80 by 50. So this I can say this could be a case of diabetic, non-ketotic hyperosmolar coma. Why not DK? Because ketones are negative. So it's a case of a diabetic coma. So now you have two things in your brain. You know normal sodium value. So normal sodium value you can see. So normal sodium value is 135 to 145 milliequivalent per liter. This is the normal range. So anything less than 135 is called hyponatremia. Anything more than 145 is called hypernatremia. So but these values are not important for us. What is the concern? If this 135 value, this is going down to 125. This we label as D for dangerous hyponatremia. And if this 145 value, if it is increased to 158 or more, that is called dangerous hypernatremia. In both the cases, the patient can develop a seizures, there will be risk of brain herniation, and because of the CNS complications, patient will die. So here now, so you can see the sodium value is high. That is true, but it is not that high. So understand, let's see the option. First, you can see RL, ringer lactate. Ringer lactate you can give. So lactate means we should avoid lactate or dextrose in any patient who is having diabetes. And it is strictly avoided when it's a case of DK. Why? Because DK already there is ketoacidosis and lactate can cause lactic acidosis. Now you can see NS, normal saline, or N by 2. If in the same question the sodium value I will write like 158, then better answer will become you have to give N by 2. But here you can see the patient BP is very low, so patient is in shock. So nothing can increase the BP than normal NS. Plain water with Ryle's tube? No. So the answer will be normal saline. So here we have to treat this acute complication, because here we should treat the shock first. For treating this, we have to give normal saline.
We already have so many correct answers.
Yeah,
They've all said normal saline. Excellent.
So that is
excellent.
Very good thing. This is like one of the question where most of the students, they mark the answer plain water or N by 2. So
like I said, N by 2. All right. So this is fantastic. Just a little physiology part here, and we can't move on without giving a little bit of physiology. How to calculate plasma osmolality? You have to take 2 into sodium plus potassium. Sodium and potassium are given in milliequivalents or millimoles per liter. Please remember, for univalent ions such as sodium and potassium, millimoles and milliequivalents is the same thing. So 2 into sodium plus potassium. Why 2? Because sodium and potassium are the cations. They are associated with anions. Into plus 0.055 into glucose in milligrams per deciliter. 0.055 can also be written as 1 upon 18. Why do we multiply glucose by 0.055? To convert it from milligrams per deciliter to milliosmoles per liter, plus 0.36 into blood urea nitrogen. For the same reason, blood urea nitrogen is in milligrams per deciliter. To convert it to milliosmoles per liter, we will multiply it by 0.36, or also this can also be written as 1 upon 2.8. So what is the major contributor to plasma osmolality? Sodium. So if there is a change in the plasma sodium level, whether it's a hyponatremia or a hypernatremia, it will start affecting the plasma osmolality or the ECF osmolality. So let's go on to the next question. Yes.
Okay, so this is like a topic which is a trending topic, or I can say a burning topic in exam from past 3 years. This is one of the topic which they're asking again and again. So you can see the question: a patient is having vomiting and no proper dietary intake for 4 weeks. So you know, vomiting can cause any electrolyte imbalance. It can lose a lot of electrolyte. There's no proper dietary intake for 4 weeks. So he was treated with IV fluid. That IV fluid is normal saline. So understand this, following which patient developed quadriplegia and became mute. What is the correct statement? Okay, so just try to understand this. This is a common thing when you do your practice in India. There are many quack practitioners. What they do, whenever a person is coming with some weakness, they will straight away insert a saline. So that is a common practice in India. Like even a normal dehydration, if you can drink water, please drink water by mouth. Take ORS with water. But what is the common practice in India? People like sometimes patient itself is not satisfied unless they get a drip. They want sometimes, like even patient, they come to me, they ask me, please insert a drip. We are feeling like lethargy, we are having a fatigue. So understand this. This is a person. This is a condition which is very commonly seen in India, but again it is misdiagnosed. So this is what we call this ODS. What is ODS? Osmotic demyelination syndrome. Osmotic demyelination syndrome, and when this condition progresses, this will reaches your pons. This will lead to loss of a myelin from the pons. So that is what we call the central pontine myelinolysis. Central pontine myelinolysis. Like, yes, some of them are saying correct.
Absolutely right.
This is locked in syndrome. Yes, this is the same locked in syndrome. So this is due to a rapid correction of hyponatremia. Okay, so just I want to add a few things about this. Remember, whenever you see a person with a sodium value, like I told you, normal sodium value is 135 to 145. Let's suppose you are having a person, his sodium value is coming 120. How much is the deficit? The deficit will be, minimum you need is 15, right? To get 135, you need 15. But remember, this 15, you should not provide this 15 milli equivalent in one day. If you try to correct this in one day, you are giving 4 or 5 liter of normal saline. That can cause this complication. So remember, rate of correction in a day should not be more than 8 to 12 milli equivalent per day. Suppose you are giving IV fluid 120, and next day if it is coming like 128, 130, that is fine. It means patient is responding. So over correction is the thing. So I can say this is something an iatrogenic or a doctor induced condition due to rapid correction of hyponatremia. Ma'am will explain some physiology part of this.
Yes, so this is why is this rapid correction of hyponatremia so dangerous? This is because of what is known as osmotic adaptation. Now, normally we know that the ECF and the ICF osmolality is the same. So if ECF osmolality is 290 milliosmoles per liter, ICF is also 290 milliosmoles per liter. This is normally what happens in all the cells. And this is very important because if there is a difference in osmolality, there is going to be shift of water. Water always moves from a dilute solution to a concentrated solution. Water will always move from an area where osmolality is less. Less osmolality means dilute solution, more water. Less solutes, more water. To an area where osmolality is more. That means it's a concentrated solution. So normally ECF, ICF osmolality is the same. But if there is a chronic hyponatremia, now when we talk in terms of chronic, that means it has to be for more than 24 to 48 hours. A chronic, we'll talk about hypernatremia first. Chronic hypernatremia, that means the sodium levels outside the cell are high, so that means the ECF osmolality has increased. I just discussed with you that the major contributor to ECF osmolality is sodium. High sodium levels means higher osmolality. Now, there will be, if there is no osmotic adaptation, there is a tendency of water to move from inside to outside the cell. To prevent that, especially the brain cells are smart, right? So brain cells, they undergo something known as osmotic adaptation. So what is this osmotic adaptation? They will increase their own intracellular osmolality. And how do they do that is, number one, by increasing intracellular synthesis of osmotically active particles. And these osmotically active particles are betaine, inositol, and glutamine. And the second thing that they do is they import small amounts of sodium from outside to inside. The net result of these two mechanisms would be that the intracellular osmolality increases to match the extracellular osmolality, so that there is no shift of water. This is osmotic adaptation in hypernatremia. Now let us see what happens to the osmotic adaptation. How does osmotic adaptation take place in hyponatremia? So hyponatremia means a reduced ECF osmolality. Now if the ECF osmolality from 290 has reduced, inside is at 290. Now I need to reduce the inside osmolality. So what do the brain cells do? They decrease the intracellular synthesis of osmotically active substances such as betaine, inositol, glutamine, and they also cause extrusion of these osmolytes. These osmolytes are thrown out of the cell, and there is export of potassium. Potassium is more inside the cell, so some amount of potassium is sent out of the cells. Now this has got another very important clinical point when I say extrusion of osmolytes, especially glutamine. When glutamine starts moving from inside the cell to outside, right? Now glutamine outside the cell gets converted to glutamate. And what is glutamate? Glutamate is the most important excitatory neurotransmitter in the central nervous system. 75% of the excitation in the central nervous system is done by glutamate. So if I have more excitatory neurotransmitter outside the cells, now this precipitates seizures. Seizures are a common complication which is seen in patients of hyponatremia. Now the reason why we are not going to do a rapid correction of sodium in a patient of hyponatremia, again chronic hyponatremia, 24 to more than 24 to 48 hours. The reason is because the brain cells are already osmotically adapted. Inside of the cells have a lower osmolality. If I do a rapid correction of hyponatremia, we are going to create a problem for this patient, which sir has already elaborated. And especially what is the risk is the central pontine myelinosis. Yes.
Okay, so there is a short story behind this. You can see, like many of you are knowing this story. This is Anarkali. So if you know, like Anarkali and Akbar story, even my history is not that strong now. So I just remember something like what Akbar was doing. He was putting the person, and if that person is doing some harm to him, he will bury that person in between the walls, means in the bricks, and up to here. So means he will apply bricks up to here, so that only his eyes you can see, other things are inside the brick. So imagine I am inside a wall, and every part is covered with bricks, only my eyes are movable. So same thing is happening in the body when you do the rapid correction. So all muscles are paralyzed. There will be paralysis of like upper limb, lower limb, tongue muscles, everything. The patient can't speak, he can't move his limbs, right? He can't go to washroom. So there's a quadriplegia, there is a problem in the movement. So all muscles are paralyzed except ocular muscles, and this is what we call locked-in syndrome. This is, you can see, locked-in syndrome. That is, it is like not a specific term for central pontine myelinosis. You can see this in many other conditions, but here you can see only ocular movements are there. All other muscles are paralyzed. So we see quadriplegia, right? Okay, so now before this, let us revise all the electrolyte in a simple table form, so that you can get at least 1 to 2 questions in exam from the electrolyte part. So let me, ma'am can give me a few minutes so that I can revise with them all the different type of electrolytes. So you can see we have 3 electrolyte and 6 their disorder, means hypo and hyper, that they frequently test in exam. So you can see the first electrolyte that we have, this is sodium. So I can write like hyponatremia. This is the first one. Okay, let me start with the easy one, with the tough one, sorry. First thing what I'm having is hypernatremia, because in exam what they test you about increase in sodium. Then there can be hyponatremia, right? Sodium is decreased or sodium is increased. Second electrolyte abnormality they can ask you is increase in potassium, means hyperkalemia or hypokalemia. And the third one that they ask, this will be your hypercalcemia or hypocalcemia. Now with these abnormalities, what they try to ask, they'll try to ask you few questions. They want to ask few questions. The first question itself they ask from the normal values. First question they'll ask you about the normal values, right? So if you ask me like sodium values, you know, hypernatremia, when it is more than 145, and when it is more than 158 we use the term D for dangerous. Simple. Hyponatremia we will call when it is less than 135, and less than 125 is considered dangerous. Potassium range is 3.5 to 5. 3.5 to 5. So hyperkalemia, we can call this when it is more than 5.5. If it is less than 3, we call this hypokalemia. Calcium comes into the range of 9 to 11. So again, you can see more than 11, and if it is less than 9. So this is about the calcium. So now understand, you have to remember these values because sometimes they will give you a clinical case. Now, what else they ask you? They'll ask you like, what is the cause of death in these electrolyte? So understand this, cause of death in a patient, whether it is hypernatremia or hyponatremia, this is a CNS issue. That is, patient will die because of seizures. So in sodium disorder, remember, the cause of death is seizures. If you see hyperkalemia, so we have already told you, ma'am told you, what is the cause of death? More potassium. This is going to be a diastolic cardiac arrest. Diastolic cardiac arrest. And if you ask me about hypokalemia, hypokalemia means less potassium. Less potassium can lead to paralysis of your diaphragm. So there will be a respiratory failure, or I can say diaphragmatic palsy. The cause of death will be diaphragmatic palsy. So when I say hypercalcemia, more calcium, now you can tell me what is the cause of death. More calcium means again this will lead to cardiac arrest, that is a systolic cardiac arrest. Systolic cardiac arrest. And hypocalcemia, patient will die because of laryngospasm. Okay, so let me simplify this. Remember, when it is hyper, then heart is involved. When it is hyper, you can see heart is involved. When it is hypo, you can see larynx and diaphragm, they are affected. Now, third question, they'll ask you about the treatment part. About the treatment part of each of these, because this is the favorite question. So let me start with the hypo part first. In hyponatremia, less sodium, what we can give? We can give NS, right? If it is very low, you want to treat this fast, you can give hypertonic saline, that is 3% NS. Or what else we can use? We can use oral salt tablet. Oral salt tablets are available, or like in simple capsule, we can add salt and give. Okay, in case of low potassium, what you give? Common logic, in case of low potassium, what we give? We give potassium. So what we give? We can give like syrup pot cloth, oral potassium syrup, or we can give injection of KCl, potassium chloride. Hypocalcemia, coming to hypocalcemia, what you give? Calcium. We will give calcium. Now, if it is acute hypocalcemia. Acute means it's a medical emergency. In that case, we have to give IV drug. I told you calcium gluconate. But if it's a chronic, like patient is not drinking milk since birth, he is just eating Maggi noodles, not drinking milk since childhood. In that case, what we are giving? We are giving calcium sandose. That calcium sandose shall call these calcium tablets are calcium carbonate. So gluconate you will prefer in acute condition, and carbonate we prefer in chronic condition. So treatment for hypo is simple, and trust me, nobody will ask you. What they'll ask you treatment of hyper. Treatment of hyper. So let me start with the treatment of, I can say first is your hypernatremia, more sodium in the body. So what you will do? Imagine more sodium in the body, what you can do? Will you give NS? No, that will create more problems. So what we give? Here we have to give a fluid which is dilute, that is N/2. N/2 is also called as half normal saline. Or what we can use dextrose. Okay, just one more thing I want to add here is like whenever you see a person is admitted in hospital, so normally patient will drink like home water, but whenever he is hospitalized due to any reason, like intentionally, like his relatives will bring a bottle of Bisleri, that is mineral water. So don't give that mineral water to these patients. So you can give a simple tap water. Is it clear? Mineral water means, minerals means sodium, calcium, these are the minerals in mineral water. So you can ask me, suppose if you ask me like hypernatremia patient, if it is diabetic, you will give dextrose or N/2, so logical, you will give N/2. Now hyperkalemia treatment we have discussed in detail. So in detail what I told you, we can give calcium gluconate. Then this is like calcium gluconate or calcium chloride. This will have antagonist action. Then what else we can use? We can use insulin and beta agonist. And third thing what I told you, we can use diuretics. And we can use binders. K binders I told you, sodium polystyrene sulfonate and sodium zirconate, and one more pyromet. Now suppose you are having a patient with hypercalcemia, what you will do? More calcium in the body. What you will do? More calcium. So whenever there is more calcium in the body, you have to get rid of this excess calcium. What you can do? Think logically. More calcium in my body. So more calcium, add water. This water will dilute this, so we can give simple saline. We can give simple IV fluid. Okay, now see, more calcium. You added water, it's still not going. Then add diuretic. Which diuretic? Loop diuretics. So you can add furosemide. You tried this sometime, like you can see a person can develop hypercalcemia due to some autoimmune condition like sarcoidosis. In that case, we have to use steroid. So steroids we can use in hypercalcemia due to some autoimmune condition, and sometimes hypercalcemia due to some malignancy. Like some of the malignancy like squamous cell lung cancer, they have a protein called PTHRP, parathyroid hormone related protein, that can increase the calcium. Okay, what else? A person who is old lady getting hypercalcemia, more calcium in the blood because she is having osteoporosis. Calcium is coming out from bones into blood, so we need to send that calcium back into bones. Who will do this? Calcitonin will do this. Calcitonin will send extra calcium from blood back into bones. No improvement with calcitonin, then what we can use? We can use bisphosphonates. This is how we manage bisphosphonates like ibandronate, zolindronate, pamindronate. So this is like a summary of the management part, and trust me, examiners, they want to test you the treatment part of all the hyper things, because in hypo there is nothing. Clear? So this will be.
Sorry.
Yes, ma'am.
So just 2 points here. When does the heart stop in diastole? Whenever there is a hyperkalemia. When does the heart stop in systole? hyperkalemia? This is a question which has been asked. And why is there a laryngospasm when there is a hypokalemia? This is because when the calcium has something called a membrane stabilizing action. If there is a hypokalemia, loss of this membrane stabilizing action causes increase in the neuronal and muscle excitability. And the excitability, for instance, in hypokalemia, carpopedal spasm, right? But yes, Schwarz test sign positive. But what we are scared of is the laryngospasm, increased muscle excitability resulting in laryngospasm, because laryngospasm will be life-threatening. So this is fantastic. You've got the entire electrolyte imbalance in a tabular form. So this is.
So I think you should take a screenshot of this and redraw this once with your own hand. Once you draw this, trust me, you will get one question definitely in exam from this.
Yes. So Sairam, I'm also happy to see you. Yes, and thank you. And yes, all right. So
Next question. I think we were here.
Just give us.
This was the question.
Right. So let's have a look at the next question. It says,
so this is a rejection of all of the following result in macrocytosis except. So understand this. The question they are asking you, like, which will lead to macrocytic or normocytic anemia. So again, this question is quite logical. If you see that macrocytosis we see in 4 major conditions. So one is your B12 deficiency. Second is your B9 or folate deficiency. Third is sometimes you can see this in liver disorders, and sometimes you can see this in thyroid disorders. So which are rare? So this is like a properly framed physio-medicine overlap question which they gave. Easy question, but still many students they made the mistake. So understand this. So let me start with folate. Folate absorption primarily I can say it is occurring in the jejunum. So folate absorption is occurring in the jejunum. So jejunum, if you reject the jejunum, there can be folate deficiency and ultimately it can lead to macrocytosis. B12 absorption will occur in the terminal portion of ileum. So when you reject the ileum, there will be B12 deficiency. Okay, just I want to just simplify this. Whenever, how is the B12 absorption is occurring? So understand this, what we have, B12 generally we get from where? We get from the non-veg food. We get B12 from the non-veg food. So understand this, the non-veg food will give you B12. This B12 will now bind with R binders. These R binders are in the saliva. So what we get, we will get B12 R binders complex. B12 R binder complex. Now understand this B12 R binder complex. There will be action of proteases from the pancreas. These proteases, they will separate this B12 from R binders. So what we get, we will get R binders separated and B12. Now this B12 will bind with intrinsic factor. And this intrinsic factor is coming from stomach. From where in stomach? Yes, from parietal cells. Right. This intrinsic factor will take B12. Where? In the ileum. In the ileum, here we will have receptors. These are called cubulin or cubam receptors. So these are the receptors for B12. And ultimately, this is the ileum. In the ileum, you will see there will be B12 absorption. So just let me make it very simple. First is B12 you are taking in diet. Second is this will bind with R binders. This pancreas protease will detach this. Then you will see this will bind with intrinsic factor. Fourth, this will be ultimately absorbed. So these are 4 major steps. Now remember, B12 deficiency can occur if you are, first reason, if you are not taking non-veg food. So first cause of B12 deficiency, which is more common in North Indians, that is vegetarian diet. Second cause, it is not given in the books, but I can say suppose R binders will be released more when you properly chew the food. It means you are not properly chewing the food. Third cause could be, suppose you are an alcoholic and you get pancreatitis. So pancreatitis means pancreas is damaged, it's not releasing protease. So R binders are not separated. Next cause I can say B12 deficiency, there is a damage to stomach parietal cells. A damage to stomach parietal cells, what we call this pernicious anemia. And remember this pernicious anemia, this is the most common cause of B12 deficiency in the world. because in world this is not like vegetarian, non-vegetarian. Most people are non-vegetarian. Now understand, here what we have B12 receptors. Sometimes these receptors are mutated. When these receptors are mutated, we call this Imerslund-Graceback syndrome. That is a congenital deficiency of B12. And the last will be any problem in the ileum. What could be the problem in the ileum? In ileum, suppose we have resected the ileum. That is a rejection of ileum, or I can say Crohn's disease that's affecting ileum. Any malabsorption syndrome, or there is a growth of certain bacteria that is called bacterial overgrowth syndrome, or there is a growth of a parasite. That parasite is called Diphyllobotrium lactum. So you can see stomach can cause or not. Stomach, if you reject the stomach, there will be no intrinsic factor. So answer for this question will be duodenal. Here. Okay, medical students more prone to vitamin B12 deficiency. Why? Because medical students during their MBBS they are eating samosa patties, right? And during their PG they are doing the same thing. And they are advising people to eat good, but they themselves are not eating good. That is the reason, like it's very common, B12 deficiency is very common in Indians, not only in medical students, it's very common in Indians.
So this is a very interesting question, which Sir has already told you about how stomach is involved in the secretion of intrinsic factor, the Suraksha Kavach for B12, and how B12 will be absorbed in the distal ileum. Folic acid, jejunum. Let's go on.
Just a little more thing I want to add here.
Yes.
You can see this is the same thing. If you see B12 you are taking from the diet, then it is written here pancreatic protease. So in pancreatitis, remember pancreatitis can also be a cause of B12 deficiency.
Yes.
Then remember this intrinsic factor, if this is destroyed, that is what we call this pernicious anemia. Pernicious anemia, and this is most common cause, and this is the receptor cubulin or cubam receptor. When these are mutated, we call this Imerslund-Graceback syndrome. Then something here, like I can say some bacteria overgrowth here, or I can say a parasite Diphyllobotrium lactum. So these are the major causes of B12 deficiency.
Pernicious anemia patients will have achlorhydria as well as microcytic anemia. Achlorhydria or hypochlorhydria, that is because parietal cells of the stomach or the oxyntic cells, these are involved in the secretion of HCl and intrinsic factor. Let's go on to the next question.
Okay, so lesion of which of the following structure give rise to hemimballism? So this question came in INI-CET paper and last year, and the same question came in NEET PG paper. Like the question was, I remember the question, same question, but a clinical case. Like a 35-year-old man is having proximal ballistic movement of upper and lower limb, strong jerky ballistic movement. So that is called hemimballismus. So we have these lesions, like you can see, like these brain disorders. These are the topics which they tend to ask again and again.
Absolutely. So I'll quickly go through the which are the neurotransmitters secreted by different parts of the basal ganglia. Now, caudate nucleus and putamen. Now, please remember a little bit, a small point here, that anatomy and physiology, how they classify the nuclei of the basal ganglia, there is a little difference. Anatomy says putamen and globus pallidus is the lenticular nucleus. Caudate nucleus, putamen, globus pallidus is the corpus striatum. But as far as physiology is concerned, we say that the caudate nucleus in putamen is the striatum. So this confusion will be there, but please keep in mind, corpus striatum means caudate nucleus, putamen, globus pallidus, but if it says only striatum, then caudate nucleus and putamen. Now, striatal neurons secrete mainly GABA. 95% of the striatal neurons will secrete GABA. 5% of the striatal neurons secrete acetylcholine and somatostatin. Globus pallidus, external segment and internal segment are both GABAergic neurons. GABA is an inhibitory neurotransmitter. Substantia nigra pars compacta secretes dopamine, pars reticularis secretes GABA. And you already know a very famous condition where there is loss of substantia nigra pars compacta neurons. These are dopaminergic neurons, and that is the condition which it gives rise to is Parkinson's. Subthalamic nucleus of Lewis is the only part of the basal ganglia which secretes an excitatory neurotransmitter, and that is glutamate. Looking at the lesions which are going to be produced, a lesion of the caudate nucleus, chorea, CC. And this question has been asked again, I think last year. Caudate nucleus, is chorea.
Chorea.
The lesion of putamen and globus pallidus, athetosis. Parkinson's we've already discussed, and subthalamic nucleus of Lewis is hemibalismus. So these are important. Again, this one slide will help you answer a lot of questions as far as your exams are concerned. Can we move on? Sorry.
So let us answer the question for this. This will be
Subthalamic nucleus. Yes. Let's go on to the next question.
Yes, ma'am.
Okay.
Okay, so this is like a simple question. They are asking you CFTR gene mutation in cystic fibrosis involve which ion and which electrolyte. So first thing you should know the ion. So ion, as you can see, chloride ion is given in all the options, so that is definitely the answer. But which like position or deletion of which amino acid, that is the question that they ask in exam. So any guesses, any answer from your side, any inputs, guys? Any input? Okay, biochemistry, physiology, medicine overlap question. So just try to understand this. This is not a defect of tryptophan. So you can see this tryptophan is ruled out. Now we have two options of phenylalanine, that is 508 and 708. So correct answer for this question will be 508. So just a few basic information about this disease. That cystic fibrosis, understand this. Cystic fibrosis is a condition. I'll tell you a story about this disease. This disease was first encountered in a mother, and this mother was trying to kiss her baby. So when she kissed the baby, she noticed her lips are turning more salty. Lips are turning more salty. That is why one more name was given to this disease called salty baby syndrome. Salty baby syndrome. So what is happening here is there is a defect in CFTR gene. The CFTR gene is defective, and this is at chromosome 7. So basically it is a chloride channel defect. It is a chloride channel defect. So there is I can say a deletion. We write like this, a delta 508 at phenylalanine. That is this is the position which you have to remember. Deletion of phenylalanine at delta 508. So as a result, there are some vital organs which are affected. So first is your lung. So disease will affect your lungs. So patient can develop recurrent respiratory tract infection. There is risk of bronchiectasis. Second is this will affect your exocrine part of pancreas first, then endocrine part. So first you will see patient can develop pancreatitis. There will be like elevation of lipase amylase. Then later on patient can also develop diabetes. So remember, first exocrine is affected, then endocrine part of pancreas is affected. The third, this will affect your sweat gland. Third and the major organ, sweat gland. So that is why you will see these babies will have more sweating. And do you know that sweat is salty in nature? So understand the disease, how we can manage. We can manage the main problem is most of these baby, they will die because of lung involvement. There is recurrent bronchiectasis. They will have mucus plugging. So question is what you do to make a diagnosis of this condition, because there is always a pediatrics medicine question on this topic. So first thing is we can do something called sweat chloride test. So we can do something called sweat chloride test. So what is the meaning of sweat chloride test? So you will we will give pilocarpine to patient. So we will give pilocarpine to patient. We call this pilocarpine iontophoresis. And something else what we can do, we can check the transepithelial difference, transepithelial potential gradient. That is something we can use to detect this condition. The point is the patient is having sweat chloride test. We can use pilocarpine iontophoresis, right? What else? Transepithelial nasal potential. This disease, once you make a diagnosis, so we have to treat the complication part. So how we treat this? So that is the question that they can ask you. So for treatment, understand this. Pancreas is affected, so we can give artificial forms of pancreatic enzymes. So we can supplement pancreatic enzymes. So you can give pancreatic enzyme supplementation, like chymotrypsin, trypsin. These enzymes we can supplement. Second is in lungs there is mucus plugging. To get rid of that mucus plugging, we have to do nebulization. So nebulization with something that will have mucolytic action. So we can nebulize this with, I can say, drugs like recombinant Dornes. We call this Dornes. We can do nebulization with a drug that is very commonly used, which is commonly available, that is called N-acetylcysteine. N-acetylcysteine. N-acetylcysteine we can also give in IV form or in tablet form. The third thing is what we have. We have a new drug for this condition that is called Ivacaftor. Ivacaftor and Lumicaftor. So these are our new possible drugs which we have for this condition, cystic fibrosis. Even nowadays, like many physicians, they are doing the nebulization part with an antibiotic called tobramycin. So that we can provide, because it's a genetic disease. It's a genetic disease, so you cannot completely cure this. So we are providing the symptomatic relief, and patient later on can develop bronchiectasis. So this is the management of this condition, cystic fibrosis. Okay, coming to next question, which of the following is seen in primary hypothyroidism? Try to answer this. Okay, try to answer this. It's a simple question. Come on. Okay, so just try to understand this. When you see this question, primary hypothyroidism. So hypothyroidism means T3, T4. Single best test to make a diagnosis of thyroid dysfunction is not T3, T4, it is TSH. And when it comes to T3, T4, you will check total form or free form. So remember, free forms are preferred. So these three things which we have to check to make a diagnosis. So now you can see hypothyroid means T3, T4 are low. T3, T4, the free form is low. This will give a feedback if it is primary, so TSH will increase. So T3, T4 is low and TSH is elevated. So answer for this question is A. Okay.
And please remember, it is the free thyroid, free T3, T4, which is responsible for negative feedback. And because the free T3, T4 are low, TSH is high. And remember, thyroid hormones, more than 99% of the thyroid hormones are in the bound form. If you can just have a quick look at the regulation. DRH secreted by the hypothalamus, it acts on the thyrotropes in the pituitary, release of TSH, and TSH in turn acts on the thyroid gland. There is release of T3, T4. T3, T4 have a negative feedback effect on both the secretion of TSH and DRH. So if there is a decrease in the free T3, T4, TSH and DRH will increase.
I think I should add something here, because this is like a very interesting slide. I was about to make this, but I already am having this. So see, not hypothalamus is releasing something called TRH.
Yes.
TRH means thyroid releasing hormone. Pituitary gland, like anterior pituitary, this will release TSH. And thyroid gland will release T3 and T4. Clear? Okay, so now just try to understand this. This is you. This is your dad. And this is your grandfather. Clear? Now understand the simple concept. Thyroid gland is the gland, pituitary is master gland, and hypothalamus is called master of master gland. Now suppose, listen to me very carefully for next 2 minutes, you will understand everything, because in endocrine, in medicine, they'll confuse only in this increase and decrease. Suppose you are having less money. You are having less money, then you will tell your dad, so your dad will give you some money. This is called primary hypothyroidism. Remember, in endocrine, the problem in the particular gland is called primary, problem in the pituitary is called secondary, and problem in the hypothalamus we call this tertiary. You are having less money, you are telling your dad, he will add some money. This is primary hypo. Now see, you are having huge money. Now you will tell your dad, so this month he will not give you money, or he will give you less. This is primary hyperthyroidism. Okay, let's suppose your dad is having a huge profit in business, so is giving you extra pocket money. This is called secondary hyperthyroidism. Your dad is having less money, he is giving you less. That is secondary hypothyroidism. Just remember, your grandfather is rich, so father is rich, so you are getting more money. That is called tertiary hyperthyroidism. Grandfather is poor, father is poor, you are poor. That is called tertiary hypothyroidism. So tertiary, secondary will not make a difference. Just you need to check the TRH level. That's it. Only in exam they will confuse you in primary and secondary. This is something like an easy thing, but students think this is very difficult.
That's excellent, Dr. Aman. You've explained it so beautifully, and I'm sure our students are not going to forget this. And let's go on to the next question. This is again from endocrinology. And
okay, so you can see the question: 40-year-old patient with hoarseness of voice. So voice hoarseness. So some trend which I am seeing like from past 2 years. 2 years before there were question on DK, diabetes, metformin, and although diabetes part of endocrine. But from past 2 years in INI-CET they are asking more and more question from pituitary. Like either a question on acromegaly or a question on prolactinoma they are asking question on diabetes insipidus. So just I want you to, like, when you revise your notes before exam, just focus on diabetes because that is already an important topic, and don't forget to revise prolactinomas, microadenomas, acromegaly, these type of topics. So you can see protrusion of chin, excess sweating, enlargement of hands and limbs, and recently diagnosed diabetes. Following drugs is used to treat this condition. Now understand this, they have not asked you about the drug, they are asking you about the classification also. So you know the diagnosis for this condition. So diagnosis is acromegaly. Acromegaly. Now tell me the answer. Okay, so see, let's see the options. Pegvisomant. Yes, pegvisomant is growth hormone antagonist. So answer is A. So what about other options? You can see octreotide. Octreotide is somatostatin analog. Do we use this in the treatment? Answer is yes. It is also used, but it is not a growth hormone antagonist. It is somatostatin analog. Cabergoline we use to treat macroadenoma. This will shrink or reduce the tumor size. So do we use this? Yes, we can also use this, but it is not growth hormone antagonist. Okay, what is olcigipant? Olcigipant. Anyone, can you answer what is olcigipant? Rimugipant, olcigipant, ubrogipant. Come on, anyone? Gpants. Gpants, what these are? These are the drugs, new drugs that we have for migraine. These are CGRP, drugs that are acting on calcitonin gene-related peptide. So these are the drugs that we use to treat migraine. Okay? So answer is clear. This is a case of acromegaly.
just a brief look at what are the actions of growth hormone. Growth hormone actions can be divided into direct actions and indirect actions. So when I look at direct actions, it increases the blood glucose level. This is diabetogenic. It's an anti-insulin. And we just saw in the question that the patient had diabetes.
Patient will develop acromegaly patient. Most of them they will develop diabetes in future.
Yes, this is because it is the growth hormone, excess secretion of growth hormone, anti-insulin action and diabetes. It causes something called a pancreatic burnout, because elevated glucose levels more and more stimulates the pancreas, and finally there is a burnout. It increases free fatty acid level. This is a ketogenic hormone. Increases protein synthesis. Direct actions of growth hormone are both catabolic and anabolic. Increases free fatty acid. This is a catabolic action, and increasing protein synthesis. This is an anabolic action. It increases sodium, potassium, calcium, phosphorus retention. Not just sodium, but sodium, potassium, calcium and phosphorus retention. And there is growth of cartilage, epiphyseal growth. Now, what are indirect actions? Now, indirect actions is that growth hormone acts on the liver, and liver produces what is known as IGF-1, somatomedin C. IGF-1 is insulin-like growth factor 1, and this is also called somatomedin C. Now, this is a question which has been asked in the last year's NEET exam. What is the source of IGF-1? Source of IGF-1 is liver. Now, since it is insulin-like, so the actions will be similar to insulin. Decreases blood glucose, causes lipogenesis, causes protein synthesis, and very importantly, chondrogenesis, important for cartilage. You wanted to add something?
Yeah, one more thing I want to add. This IGF-1, insulin-like growth factor 1, this is commercially available test.
Yes.
And this is the test that we use to screen. This is the test that we use for screening of acromegaly. Now, if you ask me how you will confirm this, so confirmation. For confirmation, what we do, we will give the patient glucose, and this test is called as OGTT, oral glucose tolerance test. What happen in normal people, you will see when you give glucose, growth hormone level will suppress. Here, acromegaly, there is so much growth hormone that will not suppress. So failure of growth hormone to suppress even after giving glucose, that is called OGTT, oral glucose tolerance test. And once you want to localize, because the most common cause is pituitary adenoma, if you want to localize the tumor, in that case, you want to localize this means you have to do a scan. So that is means you are doing a gadolinium based MRI. These are the three tests that we do. So first is screening, IGF-1 level, confirmation, OGTT, and to localize the tumor, what we do an MRI brain, because the most common cause is a growth hormone secreting adenoma.
So again, one small point here, why IGF-1 for screening acromegaly? Why don't we do growth hormone levels? The reason for that is IGF-1 is actually bound to a protein. So compared to growth hormone, IGF-1 has a longer half-life. And if it has a longer half-life, you can use it for measuring the growth hormone levels. Let's go on to the next question. Deep Y
you
descent.
can see like JVP questions they always ask in exam. So, and even like in physiology and medicine, we both teach JVP. So this is like one of the hot topic. I can say evergreen topic in exam.
Evergreen, yes.
So you can see deep or Y descent in JVP seen in all except. So it is seen in constructive pericarditis, restrictive cardiomyopathy, tricuspid regurgitation. It is not seen in cardiac tamponade, right? So JVP again an important topic. So we will quickly revise you some of the points of JVP.
This should be our last question for discussion.
Yeah,
yes.
We can conclude this.
So when we look at the examination of JVP, now JVP will always be seen on the right side. Why on the right side? Because the right internal jugular vein is in direct communication with the right atrium. So it is going to reflect all the right atrial pressure changes. And if you remember how to measure the JVP, this was extremely, this is something which we did in our clinical examination. You use two rulers and two scales, and you place it one on the angle of Louis and the other one is vertically, and you see the upper level of JVP. But very importantly, you have to keep the patient at an angle of 45 degrees. And that's how you measure the upper level. Keep a horizontal scale and then a vertical one on the angle of Louis. That will give you the JVP. Now remember, JVP is in centimeters of water. So whatever you measure, for instance, if it is 3 centimeters, you have to add 5 centimeters. Why 5 centimeters? Because from the angle of Louis to the center of the right atrium, it is 5 centimeters of water. So in this case, like for instance, I've given you an example here. The distance, the vertical distance from angle of Louis till the upper level of JVP was 3 centimeters. Add 5. So the JVP is 8 centimeters of water. Keep and take note of the unit that we are using. Now when we come to JVP, now, how to remember the important points about JVP? Now, JVP is a simple mnemonic police. This is non-palpable. This is better seen than felt. Carotid pulse is better felt than seen. So this is non-palpable. This is readily occludable because this is a vein, venous, so readily occludable. What is the location? It is between the two heads of sternocleidomastoid, lateral to the carotid artery. Now, there is a definite upper level of JVP. This upper level of JVP is more visible when you keep the patient at 45 degrees. If the patient is upright, it may not be visible because it goes behind the sternal head of sternocleidomastoid. Now, what happens to this upper level of JVP? If I press on the liver, the hepatojugular reflux may cause this upper level to rise. And during inspiration, what do I find? That the upper level falls. Upper level falls with inspiration. A sign when if the upper level does not fall or it rises.
I was about to come on this, ma'am.
Rises with inspiration, and
what is that sign called? Anyone?
Yes, anyone. What is that sign called?
If JVP failed to fall or it paradoxically increases, that is what we call Kussmaul
Kussmaul
sign.
sign. And Kussmaul sign, again, if somebody can tell me what is the condition which is going to be, which is Kussmaul's.
Okay, guys, don't confuse this Kussmaul sign with Kussmaul breathing. Kussmaul breathing is separate.
Yeah,
That is seen in acidosis, or like lactic acidosis, diabetic ketoacidosis. This is Kussmaul sign.
Right. So there are multiple positive and multiple negative waves. Which are the positive waves? This is ACV, and multiple negative waves, X descent and the Y descent. And I've already told you that the upper level falls in the erect posture. Now, if you can see the cardiac cycle, now as far as cardiac cycle is concerned, this is the cardiac cycle. Ventricular systole can be divided into isovolumetric contraction, then the phase of ejection. Phase of ejection is divided into rapid and slow ejection, and ventricular diastole is divided into 4 phases: isovolumetric relaxation, first rapid filling phase, diastasis, and second rapid filling phase. How do we know which is the ventricular systole? Between first and second heart sound is ventricular systole. Between second heart sound and the next first heart sound is ventricular diastole. S3, S4 are diastolic sounds. S3 in the first rapid filling phase due to rapid flow of blood from the atrium into the ventricles, and S4 in the second rapid filling phase. But S4 is prominently seen when there is a decrease in the ventricular compliance. So these are your heart sounds. Why am I telling you about the heart sounds? Because I would like to see the JVP with the heart sounds.
These are all MCQs which you can see.
Yes.
Here. These are
So
the
firstly,
which came multiple times.
Multiple times. Which are the positive waves of JVP? Positive waves of JVP are ACV. A is due to atrial contraction. Easy to understand. Atrial systole. Easy to remember. C wave is an isovolumetric contraction phase. What is the reason for the C wave? In isovolumetric contraction phase, when the right ventricle contracts and both the valves are closed, it tends to cause a bulging of the closed tricuspid valve into the right atrium. When it bulges into the right atrium, it causes the right atrial pressure to increase somewhat, causing a positive wave or an outwardly directed wave on the JVP, which is called the C wave. So A wave, atrial systole, that is in the second rapid filling phase. C wave is due to bulging of the closed tricuspid valve. Then the next wave is actually a negative wave, which is called the X descent. What is the X descent due to? This is due to a downward pull of the closed tricuspid valve into the right ventricle during the ejection phase. Then another positive wave, which is called the V wave. This is due to venous filling just before opening of the tricuspid valve, and the point where the tricuspid valve opens, the moment tricuspid valve opens, blood will go from the atrium into the ventricle, and you get a negative wave, which is called the Y descent. So these are what are the reasons for the JVP. Now, prominent A wave. When do I get a prominent A wave? That means atria contracting. Atrial contraction is responsible for the second rapid filling phase. When do we get a prominent A wave? Is reduced right ventricular compliance. Now, what is this? Ventricles are compliant chambers. They have to dilate as they're getting filled with blood. But if the ventricular compliance is reduced, then I get a prominent A wave.
It means basically they are contracting against some resistance. Yeah. So like where we see stenosed wall and tricuspid stenosis.
Correct. The tricuspid stenosis, and very importantly cannon wave, which is which is a question which is asked very commonly.
So just one more thing I want to add is this prominent A wave. Sometimes we also call this as giant A wave.
Giant A wave.
Giant A wave, and this is like a last year question, cannon A wave. So understand this. This is seen when these ventricles they are what you can see, these are trying to contract but against a closed wall. So where we can see this, we can see in conditions like I can say when you see AV dissociation. Where we see AV dissociation? Anyone? Where we see AV dissociation means atria and ventricles, they are beating separately. This is seen in complete heart block. Complete heart block or third degree heart block. complete heart block or third degree heart block. And this is like already we have discussed this absent A wave.
That is.
So remember, absent P wave in ECG and absent A wave in JVP, both are a feature of atrial fibrillation.
So this is as far as our JVP is concerned. No, sorry, we had to discuss the Y descent, the deep Y descent.
So
then
they sometimes ask you a question like, what are the JVP changes we see in a patient of TR? In tricuspid regurgitation, you will see like what we call this JVP. This will look like a ventricularization of JVP, or we call this, it look like an impulse, pulse wave form. This look like a waveform. Okay, so here I will give you a mnemonic to make you understand something. This deep Y descent you will see in tricuspid regurgitation, constructive pericarditis, and cardiomyopathies. And Y descent is prolonged in tricuspid stenosis. So a mnemonic which I am adding here is that is called pay tax. So pay tax means this pericarditis will have Y descent. Tamponade will have X descent. Pericarditis will have a Y descent and tamponade will have X descent. So these are the JVP abnormalities, and then these are like a repeat question. They ask again and again these type of questions in exam.
Yes, so this is as far as the integrated session between medicine and physiology, and I'm so thankful to all our students for interacting. In fact, we have the answer for Kusmol's sign as well. And so thank you so much for your participation, your interaction with us, and that is what we all look forward to. And I thoroughly enjoyed today's session, Dr. Aman, and hopefully...
Even I thought physiology is a bit boring to me, but I am also enjoying the things, because it is like when we integrate this with medicine, this becomes very interesting.
Yes, and I've thoroughly enjoyed myself, and hopefully we're going to come back with more such sessions, Dr. Aman.
Yes, sooner.
Yes, I look forward to it, and thank you very much, and see you soon.
Okay, see you in the next video. So later on, like we have a few more sessions about integral sessions, like we'll have some overlap of some other subjects. So just set an alarm in your clock about 7 o'clock daily till your exam. We'll meet with some these sessions so that you can have some crisp content in your hand before exam. So all the best, keep working hard. So thank you so much.
Thank you very much, and good night, and all the best to all of you. Thank you very much.